Hello, I am Dr. Amitabh Biswas, consultant physician diabetologist from Durgapur, West Bengal. I am chairman of the Bengal Diabetes Foundations, and we conduct every year a Bengal Diabetes Conference. This year it will be on 3rd and 4th September. So on behalf of BDF, I invite you all, please join and attend the BDCon 2022. Today there is a case study, this poorly controlled diabetes woman with genital tract infection. Miss SRP, a 68-year-old woman, returns to your clinic for a follow-up visit 3 months after initiation of empagliflozin 10 mg per day for her type 2 diabetes. She was having other medicines too, but basically with the uncontrol of the diabetes, she was started on empagliflozin 10 mg per day after 3 months before. Her glucose levels have improved generally after the SGLT inhibitors. We all know there's a highly glycemic improvement is there. But she complains of vaginal pruritus and is worried that she has a yeast infection. So we diagnose that vulvovaginal candidiasis in this patient and prescribe a single dose of fluconazole 150 mg. After reviewing her laboratory test results, we noticed that since starting the empagliflozin, her HbA1c level has improved slightly from 8.9 to 8.2%, but it's still not where it needs to be. Her eGFR is 69 ml per minute per 1.7 centimeter square. Now, sodium glucose cotransporter 2 inhibitors, the SGLT inhibitors, are increasingly important oral medication class in type 2 diabetes. With their use climbing dramatically in recent years, we all know they result in a broadly similar amount of glucose lowering compared to other oral agents, but can also reduce the blood pressure and result in modest weight loss. So, in addition to the glucose lowering effects, large-scale clinical trials have demonstrated reduction in cardiovascular and renal outcome in high-risk groups with type 2 diabetes, as well as benefiting patients with heart failure, whether or not they have type 2 diabetes. So this class of drugs, flogins, also used in non-diabetic heart failure patients. It reduces the hospitalization of the heart failure. So SGLT inhibitors reduce hyperglycemia in people with diabetes by increasing urinary excretion of glucose. And this induces glycosuria, increases the risk of genital candidiasis or infections. And both clinical trials and observational studies demonstrate a 2 to 5 to 6-fold increase in genital tract infections in people using SGLT inhibitors compared with the controls. So development of genital mycotic infection is more important and more common with SGLT inhibitors. Overall incidence in clinical development approximately 4 to 6% compared to other oral hypoglycemic agents. And this results in the patient's decision to discontinue the treatment. Many times, it has become a unconvinced problem to the patients for using these SGLT inhibitors. Though the blood glucose is controlled, blood pressure is controlled, she has reduced weight, but these genital infections make their life miserable. A number of factors have been shown to be associated with risk of genital infection. In particular, female sex and diabetes, especially when glycemic control is poor. But the combination of SGLT inhibitors with DP4 inhibitors, gliptins, offer a suitable component in strategy to achieve target HbA1c without increased risk of hypoglycemia and weight gain. We all know that gliptins are weight neutral. SGLT inhibitors have an advantage of weight reductions. At the same time, this combination of drugs, there's also a repeat profile improvement is there. So reduction in the genital infection also associated when SGLT inhibitors are combined with DP4 inhibitors. This is probably a better glucose control, although other possible mechanisms remain to be investigated. But it has been seen that if a gliptins is added to SGLT inhibitors, the incidence of genitourinary tract infection reduces. So in clinical practice, these genital infections may be a barrier preventing patients from receiving or continuing a potentially life-saving therapy. In addition to local hygiene consultation on how to prevent genitourinary infections, identifying combination therapies that limit the risk of such adverse effect, increasing strategy. Mechanism whereby DP4 may moderate flogin-associated genital tract infections deserve some comments. By far, the most straightforward explanation is that gliptin-sulfogin combination reduced glycemia and glycosuria more than the HGTV alone, thereby resulting in protection from GTI. Moreover, DBOR activity is present with some yeast, molds, and bacteria, and its inhibition may directly modify microorganism function. This highly speculative and sophisticated hypothesis is to be tested, experimented. The effect of the DBOR inhibitions in the constitutive organisms helps in this reduction in the incidence of gut infections. So it is advisable that whenever the glycemic control is not there with HGT inhibitors, it's better to combine different inhibitor along with HGT inhibitors to have a better glycemic control, to have a weight reduction, and also listen in the adverse effect, especially genital infections. Thank you very much for nice hearing.